Brenda, for inviting me. Thank you to all you TIPQC members. I have no commercial support. The aim of our project, so the Maine, the PQC for me, the Maine PQC, is sort of a toddler, especially compared to TIPQC. We started in 2018. We did Safe Sleep Initiative. We did Eat, Sleep, Console for NAS babies. But we didn't do any obstetrical projects. And I kept saying, let's do an obstetrical project. Let's do an obstetrical project. And they finally said, okay, go do an obstetrical project. So we sort of made this project up from whole cloth. Nell Tharp, who is a certified nurse midwife from the coast, was my co-director. She's since retired. But we initially were going to say, let's give a naloxone-containing first aid kit to every postpartum person who has a history of substance use. Then we said, why don't we just give a first aid kit to everyone and be agnostic about their history of substance use, and let's combine it with another couple things. So the aim of this statement was first to provide harm reduction. The opioid epidemic sort of, I don't want to say it took us by surprise, but it certainly challenged the implicit bias and the stereotypes we had of people who use substance. And that still is a problem, and it still is something that has to be overcome. We wanted to provide a first aid kit containing naloxone and recovery resources information to every postpartum person, and to partner with local community health agencies to promote better transitions of care from hospital to community settings. Now, in Maine, we don't have county health departments, except in maybe one county. So there are a lot of community health agencies loosely affiliated with hospitals or independent. And what we found is that there was often little communication. Someone would be discharged who needed follow-up for social services or recovery resources. The hospital personnel didn't know where to send them. And so by involving the local community health agencies, we wanted to promote better cooperation and communication. So I don't have to give you a big lecture about the opioid crisis. In Maine in 2024, there were 8,535 reported overdoses, 490 of which were fatal, which is a 5.7% fatality rate. 94.3% of those overdoses were reversed, often using naloxone. And 18.1% were reversed by community members and bystanders without involvement of EMS or law enforcement. Our governor has always supported greater access to penetration of naloxone into the communities. And the state has purchased nasal naloxone kits, and they're available at no charge and without a prescription. So saturation of naloxone has been a statewide objective. And over the last 4 years, our overdose numbers have fallen by 16%, I'm sorry. But our fatal overdose rate has fallen by 32%. And I think you can assign that almost entirely to the presence of community naloxone. Thank you. So, of course, the postpartum period is unique. It may precipitate all kinds of things. We heard about cardiomyopathy and heart failure. It can certainly precipitate opioid use and relapse of people who've used substances in the past. I'm a founding member of the Maine Maternal Mortality Review Committee, and 24% of pregnancy-associated deaths, and this is pregnancy to 1 year postpartum, in Maine from 2018 to 2022 were due to opioid overdose. And it's the single greatest cause of pregnancy-associated deaths in the state. Most of these were postpartum. And a not that recent anymore Massachusetts study showed that 50% of overdoses occurred in people who had no prior history of substance use. And that may be a little different now because we are asking the question where when this study was done, no one was asked about that. But still, people use substances, we don't pick up on it, they may overdose postpartum. So our goals were to reduce the stigma associated with naloxone distribution through harm reduction and bias education to OB staff and providers. We wanted to make this harm reduction education normative when onboarding new hires. So we made it part of the orientation process, and we called it net learning, but the learning modules that all new hires, not just obstetrical hires, but all new hires had to go through. We wanted to increase acceptance of naloxone as part of the family first aid kit, recognizing that it may not be the person we give the kit to who might need naloxone. It may be a neighbor, it may be a family member, it may be the child who got into narcotic analgesics that went home with the patient. And our overarching goal was to reduce maternal mortality. Now, in a state the size of Maine, it's hard to measure that. And so we used the distribution of the naloxone, the acceptance of naloxone, as a proxy for reducing mortality. So we created 3 PowerPoint education modules. One was an introduction to the project, which I did. One was harm reduction and implicit bias education, which a consultant who has a long history of opioid use counseling created. And my co-director created a PowerPoint teaching nurses how to teach people how to use naloxone. So all postpartum people were to receive naloxone education and be offered the first aid kit at discharge. The kit contained naloxone, a digital thermometer, some Band-Aids, some educational materials, a poison control magnet, a suicide hotline information, and a list of community recovery resources. People could decline the naloxone, but we scripted it such that the expectation was to accept naloxone. So we sent people home with a first aid kit, even if they declined the naloxone. One thing we did, and we hadn't thought about early on, and our mental health consultant brought this up when he presented to his family. He presented the project to his wife, who said, "Why would you ever want to do that?" And then he presented it to his teenage daughter, who said, "That's the coolest thing I've ever heard." So what we decided is that we were going to start educating people during pregnancy. So at 32 weeks and at 36 weeks, again, we had a scripted presentation by the office nurses about the project, how great it is, and we hope you'll accept it, so that we didn't blindside people. The last thing you want to hear for the first time after you've had a baby and you're recovering, I got to get out of here and get back home, is, and we have this project that you haven't heard about. So start in the office. Make sure that the office staff buys into it, and we put posters up in all the offices, and that was a good thing. We hope that providing naloxone to all postpartum people would reduce the stigmatization of those with opioid use disorder and increase community saturation of naloxone. And again, this may save the lives of family members, neighbors, children, and we just wanted to have people internalize it as everyone should have naloxone around just in case. And our state has done, I have to say, a wonderful job doing that. And most of the people I talk to either carry it in their vehicles or have it in their purse or have it at home. The first hospital that we implemented this in was the hospital that I practiced at. So we did about 250 to 300 deliveries a year. They really couldn't say no to me. So we first got buy-in from hospital leadership. We went to the providers and the office staff and got buy-in from them. We went to labor and delivery staff, and we had a combined labor, delivery, and peds unit, and postpartum and peds unit. So we were able to staff it pretty well. Again, been there so many nights on call, they really couldn't say no to me. We collected data on the number and percentage of people who received harm reduction education, and this was by the nursing staff, accepted the first aid kit, were offered naloxone, and accepted naloxone. And again, it's hard to quantitate overdose out there in the community, and it's hard to quantitate maternal mortality effects with so few people. So we used acceptance of the kit with naloxone as a proxy. This is our first aid kit. Different hospitals have used different ones. Some hospitals will brand it with their hospital and some of the contents. I have to say the digital thermometer is the biggest hook to accepting the first aid kit. And in talking to Dr. Alvarado, I think the plan is to have a digital thermometer there. Everyone wants another digital thermometer at home, right? So people were willing to accept the kit, with or without naloxone, as long as they had the thermometer. So you all have done a lot of QI, and you know what's successful and what's not successful. How many of you out there are labor and delivery or postpartum nurses? All right, so you all know who does the work on the OB unit, right? It's not the docs come in, oh, what a wonderful baby you've got, right? They're the midwives, you know, it's the nursing staff. And if the nursing staff buys into this, the project's a success. If the nursing staff doesn't buy into it, the project is not going to be a success. Because we chose my hospital as the pilot site, they had to buy into it. And I was up there quite a bit on labor and delivery. I gave presentations. I collected all the data there. And so they did an excellent job. And again, when I give this talk, I always credit the nursing staff, because you all know that QI, there I said y'all, I've been in Tennessee now for 12 hours. You all know that the nursing staff has a lot of straws on their back, and you don't want a QI project to be the straw that breaks the camel's back. And sometimes I say, those who can do, and those who can't, think up quality improvement projects for those who can. But, so buy-in by the nurses is the biggest factor for success. Partnering with the community agencies that offer prevention and recovery services is essential. We got grant support to buy the initial batch of first aid kits for each hospital. But after that, it was the expectation that the community health agency would get the grants to provide for the continuation of the project. We required at my hospital that staff and providers view the harm reduction modules. And that's been more or less successful at various hospitals. But again, we wanted to make all these things normative. Staff had to recognize and put aside their personal biases. We actually had a verified questionnaire about bias that we administered to staff. But unfortunately, there was some viral infection that came around in 2020, and half the staff retired and half the staff turned over, and we had a bunch of travelers. So we weren't able to actually reproduce the effects of the questionnaire on. Again, we had to remember to introduce this project to pregnant people in prenatal visits instead of at the last minute. And we scripted for the nurses ways to offer the kit and to take the naloxone and the benefits of taking the naloxone. Again, staff and provider buy-in was huge. We were a little surprised we got some community pushback. The hospital ran an article in the newsletter, a community newsletter about the project, and people started posting on the Facebook page, why are we doing this? Why are we doing these addicts? You know, why are they getting pregnant? Blah, blah, blah. And the nursing staff actually were our best ambassadors. Especially the med-surg nurses were a little iffy, but their nurse manager really bought into it, sat them down and said, you know, this is a worthwhile project. You need to participate in it. And it worked. And she was an individual who had a lot of standing in the rest of the community, especially in the faith community. So that helped us a lot. I went on the local access cable TV station and gave a talk. That may or may not have been helpful. It was important. The last hospital we expanded to, and I'll show you the data, the 3 hospitals that we started at were typical Maine hospitals, completely white, rural. One of them was on the coast, but they were basically the same hospital times 3. The last hospital we went to was an urban hospital that had a fairly high immigrant population. There were 4 to 6 different languages being spoken. We were able to publish the pilot study, and I think that's how Tennessee learned about this project, and also Brenda giving us a call. So the first 3 hospitals, this is a year's worth of data for each of the hospitals. 94%, or 90+% of people got into the nursing QI education. 94% accepted the first aid kit. 74%, and this is aggregate data, accepted the kit with naloxone. So we were pretty happy with that 3/4 of people taking naloxone home. The last hospital we used, again, very different demographics, multiple cultures, higher volume. The staff was extremely stressed. They had no nurse manager. There was a lot of turnover. We did have some good committed champions, and we were able to do one community focus group in the Somali population with using a local resource, and that was very successful. But we were only able to do the one. And so again, their numbers weren't quite as good. They had maybe half of people had the harm reduction discussion, using 8 months of their data. Not that great, but a big challenge, and there was a lot going on in the hospital. So any quality improvement project has to deal with the environment, and this shows how different it is in the environment. We think the program is worthwhile. We hope it saved lives, although it's hard to prove. And it does my heart good to know that the state of Tennessee sees some value in it, and are going to adopt it. So we have an online toolkit, which will be in your packets.